Good morning, everyone. I'm going to talk about the use of benzodiazepine in anxiety disorders. What are the risks and benefits? Well, for starters, I'd like to talk about evidence-based guidelines. In present time, we are using the nice quality suggestions, the proposals. This is about the identification of a specific anxiety disorder, severity of its symptoms, and associated functional impairments. This is proposition number one, and after this first statement, we can talk about the second statement, which is application of evidence-based psychological interventions, and the third statement is about avoiding the prescribing of benzodiazepine or antipsychotics unless specifically indicated. And this is to be found in nice quality statements. To summarize, we understand that benzodiazepines are associated with tolerance and dependence, while antipsychotics are associated with a number of adverse effects. So it's not recommended routinely in anxiety disorders and only used to help short-term crisis. We have another treatment guideline from Canadian clinical practice. The benzodiazepines may be useful as adjunctive agents in early periods of treatment, particularly for acute anxiety and agitation, to help patients that have suicidal ideations. This is mostly related to dependency, and it must be used when necessary, and it must be administered in regular doses. Let's continue. Another guideline says benzodiazepines can be added to antidepressants in the treatment of panic disorder to achieve swift treatment response. So the treatment should be reduced and stopped, if possible, in 4 weeks. In this treatment guideline, Mr. Bandello also mentioned, especially among first-line treatment options, we see SSRIs, alprazolam, clozapam, and lorazepam are the second-line treatment. Going to general information on the topic, benzodiazepines, like Mr. Bandello said, are used quite often. 58% is one figure from a meta-analysis, and rates of inappropriate prescription of benzodiazepines is 2.2 to 17.6%. Women, elderly patients with poor physical health are at greatest risk. And looking at recent studies, especially a substantial number of patients who are on long-term benzodiazepine treatment tend to develop physical addiction, and continuous use of lower doses of benzodiazepine after an overdose are also associated with this condition. Again, inadequate education of health care professionals on dealing with anxious and stressed individuals. This is another problem. In a study from our country, we find that it's prescribed often in discharge and associated with diagnosis, suicide, and age. The Z drugs, namely zaleplon, zolpidem, and zolpidlon, are used as hypnotics, especially in the recent years. Here we ask, is it a lesser evil? Why should we use benzodiazepine, or why should we prescribe them? From an efficacy and pharmacokinetic point of view, we see anxiotic, induction and maintenance of sleep, anti-epileptic and muscle relaxant, apart from its anxiolytic effect. Again, let's talk about recent studies. We know that long-term effect drugs are used usually if there is not a problem with the liver in alcohol withdrawal treatment. We can also talk about cannabinoid craving syndrome, and we have to be careful with substance use disorders, especially we need to have caution with patients on opioids. We have to be careful and probably practice a follow-up. We also know that patients with chronic resistant anxiety disorders are candidates for this drug, but people who are self-medicating with alcohol and illegal substances in order to cope with anxiety is a great problem here. And in cases of comorbidities, can we prescribe benzodiazepine for a long time? Is that in a sense accepting addiction? We have to ask these questions. What about the comorbidities? And I have noticed it in the recent years, so I added these articles. Especially in schizophrenic patients, we have difficulty in patients that have accompanying anxiety and insomnia. We can know that long-term treatment using benzodiazepine causes problems, including impairment of memory. So during the first episode and exacerbations of illness, short need and as needed use is recommended. Why shouldn't we use benzodiazepines, or what are the challenges? First of all, classically we know that they might cause sedation, drowsiness, cognitive slowing, and anterograde amnesia are dose-dependent side effects. Again, a tolerance develops to sedation and drowsiness. However, cognitive symptoms persevere, and decreasing a response to psychological states. There is another interesting question. Depending on those half-life and potency, benzodiazepines administration can result in an impairment of performance whilst driving, similar to the scene with alcohol consumption. There is this practice in UK. Patients who are on benzodiazepines are to be reported to the motor vehicles department. I don't know whether something can be done in our country, but this is a problem. Benzodiazepines can result in disinhibited or impulsive behavior, and in predisposed individuals they may release aggressive behavior towards others, in theory, of course. Again, when prescribing benzodiazepines, as Mr. Bandello also mentioned, we have to be careful, especially in patients that abuse substances. We have to focus on symptoms, and if possible, we should prescribe a single benzodiazepine, and strongly recommended is the follow-up of a physician and deciding prescribing after consultation. And the physician should never become like a shopping point, and we have that kind of problems in clinic as well. Another problem is, of course, addiction, and when we talk about benzodiazepines, we have green prescription. The withdrawal symptoms are important. If such symptoms emerge, so does the addiction. There are some symptoms of withdrawal, of course, and I will not cover this slide in detail, but are these symptoms of withdrawal or are they symptoms of anxiety disorder? This is what we need to differentiate. It's challenging in the clinical practice. The withdrawal reactions usually are reported to last shorter than a month. 1 in every 4 patients, the symptoms can be present for a longer time. Well, is this withdrawal disorder or is it an exacerbation of anxiety disorder? This question is very important to ask. And finally, we have guidelines, we have the recommendations in the guidelines, but in everyday practice we might run into some inconsistencies. Future prospective studies are needed to determine and compare addiction development and remission rates of anxiety disorders, and it's crucial to the clinicians continue to evaluate risks and benefits of benzodiazepines. I would like to thank you very much for your interest, and only very briefly I'd like to say a few things about pregabalin, as the previous speaker said. When I used to work in Ankara, we had an approval for the extensive anxiety disorder, but as we speak, we cannot use this drug because we don't have any approval for this, and the reason is the lack of studies related to this medicine. And thank you very much for your